So basically, we'll be speaking on topography, biometry, abrometry, and other measurements that come with it. So let me start my presentation with this case of a 42-year-old lady who had I had operated her left eye in 2014. Patient was not very happy, had complaints of halos, after images, and diplopia. And now she comes with the other eye surgery at 2017. Now, what differently I can do? In the course of my presentation, we will understand this. So now when we talk about accuracy of our outcomes, a benchmark was given by Royal College of Ophthalmologists, which stated that at least 55% of the patients should be around plus or minus 0.5, and 85% should be around 1 diopters. But a more realistic figure in today's times would be that you should achieve about in your 50% of patients around plus minus 0.25, and in 90% of patients it should be 0.5 in order to give a very predictable outcome for your premium IOLs. Now, before you start into premium IOLs, you should assess what exactly are the tools that you have, or what would you like to have it when you are planning for such a practice. So if you have a conventional biometry, you have to look at these measurements to be taken separately, and you need to input them in your online formula. That would mean that you have to be very careful about transcript errors. Most of us and most of the newer purchases are now all-in-one biometers, which have all these measurements in one click, along with the latest formula. So you get everything in with one button click. And you have to also think about ancillary measurements, see which clinics have these instruments available nearby your clinic, so that you can get these measurements done as and when necessary. The principles remain that you should avoid putting any drops before measurement. And if at all the eyes are very dry, you have to wait for 5 minutes at least after application of the drop. Get both the eyes measurement done, even if the patient is coming for one eye. And you need to take these measurements in undilated state, because you need to understand the pupil dynamics also. So in our setup, what happens is the optometrist does the initial checkup and he diagnoses the patient to have cataract. He hands over a cataract questionnaire, which basically tells us about the patient to fill up, and it tells us about patient's lifestyle, his spectacle use at present, post-op expectation of spectacle use, and opinion about quality of vision. So this information is usually helpful to understand what the patient needs. So after the patient has undergone this thing, he undergoes a manual keratometry and a biometry. Then, if at all is fit for toric and multifocal, he undergoes Varion and Pentacam. And after that, the patient undergoes IOP measurement, dilatation, and then further retinal checkup, and if required, OCT also. So these are the measurements that we are looking at. If you're thinking about premium IOLs and getting the things right, let's see one by one. The first thing that we need to see is patient has astigmatism and is a candidate for toric IOL. You should answer these 4 questions before you actually decide the patient needs a toric IOL. The first question is the magnitude and axis of astigmatism correct? Now, we all know that there are many ways of measuring corneal astigmatism. So in our place, we did a small study of about 18 eyes of all these young patients young interns who join us for optometry. And we basically did manual keratometry, odometry, Aladdin measurements, Varion, and IOL Master 700. And we were surprised to see the results. And if the ones which are highlighted in red, you can see that the auto K values are quite different from the other values. And the ones which are highlighted in green, you can see the manual K is quite less than the ones which are measured by the other thing. But one thing that is there consistently is between Aladdin, Varion, and IOL Master, at least 2 of them are showing consistently same values. Now, when we come to magnitude of astigmatism, we found that 2 eyes had a significant difference in the magnitude. Similarly, axis 3 eyes showed different axes. So in short, basically, you will get different axes, different values. So what you need to look at is at least 2 out of 3 instruments should show agreement in reading. And if there is so much of variation, then it's better to identify the cause, give a lubricant treatment for a week. And if you get consistent reading, take up the patient. If you don't get, you can still take a median reading and go ahead with the treatment. Now, next question that we need to answer is whether the astigmatism is regular. Now, the best way to know this is doing a corneal topography, because it gives you an impression of the patient's cornea and tells you whether the astigmatism is regular or irregular. So this is an example of a classical with the rule, astigmatism, symmetrical bow tie, and this is against the rule, symmetrical bow tie. And these are the patterns which will give you the best predictability in terms of the outcome. And here you see asymmetric bow tie patterns and symmetrical bow tie with skewing of axis. These are the conditions where the predictability is slightly less. And of course, the topography will tell you that these are the patterns that you have to avoid doing a toric IOL. Now, next thing is whether the astigmatism that you have got is it consistent or not. Let's see an example. This patient came for a cardiac evaluation and underwent IOL master 700. It gave a cylinder of 2.37 with our IOL power of 14.77 at 118.4. We called this patient for a topography, and to our surprise, the topography showed very minimal astigmatism. We repeated the IOL master on the same day, and it came as 0.79 with the IOL power at 16. So much of difference can happen if you just rely on one machine to give you the calculation. The next comes is whether it matches with the clinical astigmatism. Here is a patient who is a 45-year-old myope who has never had used astigmatic correction, but the retinoscopic value and keratometric value shows high cylinder. So there is a there is a refraction, keratometry, and retinoscopy mismatch. When we did this topography of this patient, we can see a hot spot here in the superior cornea, which is just encroaching the 3 millimeter zone. So most of the instruments will pick up a cylinder around here, but we have to understand that this hotspot is not producing any refractive astigmatism. Very important is that you should put all these patients in a retroillumination to pick up subtle findings like this. This is a EBMT and this is a posterior polymorphic dystrophy. Unless you put them on a retroillumination, it's very difficult to diagnose these subtle changes. In this patient had just contact lens induced scars which were causing this issue. So this patient didn't need the toric IOL. Next comes the axial length accuracy. Now we have seen generations of instruments available to us, and now it's very clear that swept source based OCT biometers are the ones which are of choice because we are able to get biometry in majority of the cataracts. PCI based and OLCR based biometers are also there. Then comes immersion A scan, and then finally the contact A scan. So the technology has advanced, but can we leave this technology to do everything? Let me share with you an interesting case. This was a patient who had IOL master 700 and was given the lens according to the IOL master report, and patient developed a 14 diopter refractive surprise. The axial length shown by IOL master was 35 millimeters, and according to that, 5 diopter lens was posted. When the measurements were repeated, it was just 21.67. And this was a case report which was published in one of the journals recently. And the reason why it happened was because there was a smeared optics on the swept source. So this, the authors also acknowledge that it did not really correlate with the clinical refraction of the patient. So it's very important to correlate clinically the values. Coming to the other measurements, all these measurements one has to take because all the newer IOL formulas want this. And if you're planning to buy newer biometer setups, so you can always compare this across different things and see where exactly what things are available. So accordingly, you can take a choice. Similarly, the topographers have different things available, so you can make a choice based on that. Most important is validation of the findings that come in. So most of these biometers come with a validation criteria. For example, this is IOL Master 700. It tells you that if you get an astigmatism more than 3.5, you have to do a topography to rule out ectasia. So following the validation guidelines really improves the accuracy. Pupillometry is very important because large pupil is not at all a candidate for multifocal IOLs, so one has to be careful. Coming to the formulas, now there is no doubt about it that the formulas essentially Violet Universal 2 is now accepted as the formula of choice, as is shown by this landmark study by Dr. Mellis, where he studied more than 8,000 eyes, and they've shown that almost 50% of the patients with Barrett achieve around 0.25. And across the axial lens from 22 to 20, from 22 to even more than 25, there were quite less errors in the thing. So if you take the gist of studies which is available now, you divide your patient into 3 groups: less than 22, 22 to 26, and more than 26. The middle group will give the best results. Almost 80 to 90% will achieve less than within 0.5. And the less than 22 and more than 26 group will give a moderate success. And these are the formulas of choice. Barrett is number 1. Kane is also there. Olsen and Hill RBF. Olsen is, of course, a paid software, and Hill RBF works mainly for LensStar. So if you take about this IOL Master for Kane, it is also available freely online. And how it differs from Barrett is basically you need to input the sex of the patient as well as the central corneal thickness. With regard to the toric IOL, also the Barrett has kind of standardized. But the interesting part of Barrett is it gives you what is called as integrated K, wherein you can input values from different instruments, and it will give you an integrated K based on the values that you have given. And this is fairly accurate to give you the results. Coming to angle kappa, now we all know angle kappa. If the angle kappa is large, these patients will develop problems when you put multifocal IOLs. But angle kappa is difficult to measure. So only OpScan and Synapto 4 can do it. So now more realistic thing is what is called as chord mu is done. And chord mu is essentially a two-dimensional vector which measures the distance between pupillary axis, that is center of the pupil, and the visual axis. And angle alpha, more importantly, in patients with multifocal IOL, which basically measures the distance, again, two-dimensional vector distance from the center of the limbus to the visual axis. Now, the cutoffs that are given for different machines are as shown here. With OpScan, anything more than 3 degrees is significant. For Pentagam, X decentration is of more than 0.2. With IOL Master 700, you have what is called as Chang variant chord, which if it is more than 0.6, it is significant. And with TiTrace, you get angle alpha. So this is Pentagam. This is IOL Master's Chang variant chord distance 0.2. And this is iTrace, where you get angle alpha. Anything above minus 0.5, 0.6 is significant. You would avoid putting a multifocal IOL. Then you come to aberrations. Aberrations, as we all know, are basically imperfections in the eye, which leads to poor quality of vision. So you have lower order aberrations and higher order aberrations. Higher order aberrations constitute a very small percentage of total aberrations, but if they are present, they are a definite contraindication for doing multifocal surgery. This is the cutoff for higher order aberrations. So any higher order aberration, be it coma or trefoil, if it is more than 0.2 at 4 millimeters, you should be careful. And if the total higher order aberration values are more than 0.3, then it's not the patient is not a good candidate for multifocal IOL. And any spherical aberration above 0.1, it has to be treated with an aspheric IOL. So this is an example of Pentagam pre-cataract report. It will give you these two values. The +1 basically is the spherical aberration, and 0.4 is basically the higher order aberration. So this patient is basically post-LASIK, and they're definitely not a good candidate for multifocal. Another example of this thing from iTrace. Here you can see in the right eye, it shows a higher order aberrations around 0.3, and in the left eye it's around 0.16. And this is in the right eye. There you can see a decentered ablation which is causing this. And again, this is not a good candidate for this thing. This is Aladdin. Again, it gives you these values, RMS at higher order and the coma. Again, this is basically a keratoconus and not fit for the procedure. Another interesting case I just want to share with you. This is basically a patient who is fit for multifocal, except when we did a higher aberration study, you can see a very high coma values here. And when we investigated this patient further, he gave a history of doing a lot of hot compresses a week prior to coming to us for a style. And then we did nothing. We just asked the patient to come back again. And you can see that the coma values are reducing with every subsequent visit. And by 1 month, the patient was absolutely fine. So this is, So this is how aberration profiling can help in deciding whether a patient is fit for the procedure or not. So this, now coming back to the case with which I started. So that patient, we in the right eye, we advised to do a eye trace, and we found out that the patient has a very high angle alpha, almost 0.68. Now, because we have done multifocal in the other eye, this eye also we are committed to do multifocals. In the other eye, we had done restore. In this eye, we chose to do a Technis multifocal because the central ring of the Technis multifocal is bigger than the restore multifocal. So probably this will get tolerated better, and it happened that way. The patient did well after the surgery. So in conclusion, I would say that this checklist of the measurements should be done very, very, very carefully, and we should make sure that we don't miss on anything before we advise for our multifocal patients or for a toric patient. And even if you don't do 2 or 3 tests, it's fine. You will get a very good result. But that 1 or 2 patients who are unhappy because you have probably not done that, that's what's going to make the difference. So with this, I would like to thank you for your attention.